I'm John Strum, and this is Real Talk MS. It's Tuesday, March 4th, and we have a lot to talk about. Last week, I traveled to West Palm Beach, Florida, where I joined 1,800 other attendees at the America's Committee for Treatment and Research in Multiple Sclerosis annual conference, more often referred to as the ACTRIMS Forum. At the ACTRIMS Forum, I had an opportunity to speak with a number of MS experts, several of them award-winning leaders in the field of MS research. And next week, you can look forward to lots more content from the ACTRIMS Forum, both on the podcast and on our YouTube channel. I flew back to Los Angeles less than 36 hours ago, and I wanted to share a couple of my ACTRIMS conversations with you. So this week, I'm sharing my conversations with Dr. Lilyana Amezcua and Dr. John Corboy. Dr. Amezcua is the Division Chief for Neuroimmunology and Multiple Sclerosis at the University of Southern California Keck School of Medicine, and she's spearheaded the creation of the Alliance for Research in Hispanic MS, where she serves as Principal Investigator. Dr. Corboy is the Director of the Rocky Mountain MS Center at the University of Colorado, and he's also the Principal Investigator in the DISCO-MS clinical trial, which is the largest clinical trial to focus on the often considered and discussed question of whether it makes sense for someone over the age of 55 or 60 to discontinue their disease-modifying therapy. So, in a moment, you'll hear my first conversation at the 2025 ACTRIMS Forum with my guest, Dr. Lilyana Amezcua. Dr. Lilyana Amezcua is an associate professor of neurology, a diversity, equity, and inclusion champion, and the division chief for neuroimmunology and multiple sclerosis at the University of Southern California Keck School of Medicine. Dr. Amezcua spearheaded the Alliance for Research in Hispanic MS and serves as principal investigator. The Alliance for Research in Hispanic MS is focused on better defining racial and ethnic health disparities by examining modifiable factors like social determinants of health and environmental factors from non-modifiable genetic factors involved in MS severity and progression, specific to the Hispanic and Latino population. And we're going to be talking about that in just a moment. But first, welcome to ACTRIMS 2025, and welcome back to Real Talk MS.
Great. Thank you for having me. It's really exciting to be here and be able to talk about something so dear to my heart.
Well, let's get started. Tell me what the Alliance for Research in Hispanic MS is all about.
Well, it's really about bringing together those with similar thoughts and researchers. And this started off about several years ago, not several, more than 5 years ago, actually, where I was getting started trying to better understand Hispanic population locally in California. And at the same time, there were others that were quite interested in doing the same. And this was Dr. Jacob McCauley at University of Miami and Dr. Angel Chinea in Puerto Rico. So we all had similar ideas as to how we should approach this issue of underrepresentation of a population that was fast growing in the United States, but also in our understanding that they also get MS. And so we basically came together and we decided to call it the Alliance for Research in Hispanic MS. And then from there, we started aligning our clinical data collection as well as our biosamples.
Collaboration seems to make everything better. I've noticed, especially when you're dealing with MS care, MS treatment, MS therapies, so that's a great idea.
Absolutely.
So you're the lead author in a paper that was just published a couple of weeks ago titled Person-Centered Social Determinants and Neighborhood Deprivation Associated with Disability in Hispanic People with Multiple Sclerosis. It's a long title of an important paper. I've known about social determinants of health, but I haven't encountered person-centered social determinants of health. Can you explain what that means and what your paper explored?
Absolutely. So, and as you know, John, social determinants of health are those factors that people are born to, grow to, and live to to age and die, right? And they have become rather important in our understanding and how they may affect whether it's disease, disability, and MS and any other condition. They really are a big part of how you either deal with it or are able to be resilient. And so in MS, we've come to understand that they are a big part of why we have either health disparities, whether it's by race or by age. There's these differences. And so a lot of our understanding of these social determinants of health comes also from looking at just neighborhood. There's a lot of, obviously studies that have focused at looking at what we call indices. So using geocoded data to better understand where people live, zip code, and from there inferencing what might that look like and their effect on, in this case, disability measures. And so, and we've been quite interested in understanding that. But, when we're thinking about, okay, if we do find that, how would then we would make a solution or create a solution if it's not really patient-centered or individualized, right? And if we want to start learning about interactions, we need to go deeper than just geocoding. I do think geocoding has a place. Maybe it's a place to start understanding that there's differences. But the other aspect is that, unfortunately, a lot of neighborhoods in the U.S., maybe not all, were not done at random. They were, either a result of segregation or redlining in certain regions, right? And so it might just capture that and may not give us enough information as to what we would need to solve. And so we went ahead and took 170 patients, Hispanic patients, with early MS. We're really talking about a really young population in their 30s with disease less than 5 years. On average, they had 2 years with disease. And we wanted to better understand their person-centered. And what we call person-centered was basically factors that we were going to understand about them. What is their language? What is their household? How many people live in their house? Are they employed? Are they not? So really individualized and centered as opposed to just looking at their zip code. We also did look at their zip code, and we estimated what we call the social deprivation index. There's variations out there. There's social vulnerability, there's deprivation, there's the area deprivation index. They all are very similar, but they mean something different, or they were basically made for different purposes. So the deprivation index was made to try to assess what resources are needed in the area. The area deprivation recently has, some difficulties because I guess its major focus is housing, and so that may be some, deficit to consider in the future. But in this case, we took the social deprivation index and we also looked at person-centered. And we wanted to understand, okay, which one is really associated with different levels of disability. In this case, EDSS, which is, our more common disability scale. We also looked at 25-foot walk. We also looked at the Hauser ambulatory, scale, which should be the same. If you're going to see it in the EDSS, we're going to see it in the 25-foot walk, right? And the Hauser. And so then we also looked at SDMT, which is a symbol digit modality test, which is for cognitive. And then we looked at different models. And we tried to estimate person-centered factors based on their weight. And so, for example, the principal components, one, and maybe this is too much detail, but basically what we found was that 20 to 60% of the variability could be explained by social determinants of health in terms of who is doing worse, so meaning they're slower in their walking, higher EDSS, higher, SDMT scores. They could all be explained by these factors, and depending on these factors where they were mapped, was contributing greater variability. In this case, in the Hispanic population, what came to be was that socioeconomic status and assimilation factors, which has to do with language, right? That has to do probably with health literacy, are rather important for this population. and they have a greater effect in their disability levels than other types of social determinants of health. So you can look at every social determinant of health, but not each one is as important. And in this case, these are rather important. The assimilation is actually rather, this means that we need to do more health education, health literacy, which is practically what you're doing. And so that's sort of the nuts and shells of this paper, but it's just telling us that we need to go deeper for future studies to better understand person-centered as opposed to just doing geocoding.
That makes sense. Sometimes it feels like when we talk about social determinants of health, it's easier, far easier to identify the problem than to implement solutions.
That's right.
I think this is really important work, and I'll admit, I'll give everybody a sneak peek at something I didn't know I'd be talking about to you, but as a matter of fact, dealing with health literacy, we're going to be launching Spanish language version of Real Talk MS because about a year and a half ago, you suggested I think about doing that. So I took your suggestion, and we're going to launch it with this episode.
Oh my God, this is amazing. So I will certainly let me know how I can help. I can speak Spanish, and I would be happy to connect this with the Alliance for Research in Hispanic MS. And really, I think this will definitely have a huge impact to the population, which this is what they've been asking for.
Well, Dr. Lilyana Amezcua, thank you for all you do to improve the lives of people living with MS, even when it means asking hard questions. And thanks so much for talking with me today.
Thank you so much. It's been a pleasure.
I've had the good fortune to speak about aging in MS with Dr. John Corboy before. At the ACTRIMS Forum, we dove deeper into this subject, and I certainly learned some things I hadn't known before. In a moment, you'll meet my guest, Dr. John Corboy. Dr. John Corboy founded the University of Colorado MS Center, which morphed into the Rocky Mountain Multiple Sclerosis Center at the University of Colorado. He's also the principal investigator in the DISCO-MS clinical trial, which was the largest clinical trial to focus on whether it makes sense for someone over the age of 55 or 60 to discontinue their disease-modifying therapy. Welcome to the ACTRIMS Forum 2025, and welcome back to Real Talk MS.
Thanks, John. I'm happy to be here, and thanks for having me.
As the population ages, we've seen a greater focus on the whole subject of aging in MS. How many people over the age of 55 are living with MS?
A substantial number of people in the United States and around the world are living with multiple sclerosis who are 55 and older. The best data from a large demographic study was published several years ago suggests that of U.S. adults, 46% are 55 and older. And we have for many years just thought of MS as a young person's disease, but in reality, there are many people who live long lives and are living longer lives now. The likelihood of dying early from your MS is also diminishing. So people are living older and older. We're diagnosing older people with MS. And just from a numbers point of view, it's almost half of people are 55 and older.
So we're looking at somewhere in the neighborhood of 500,000 people.
Somewhere in the neighborhood of 500,000 people. That same study I mentioned suggested up to 1 million people in the United States have MS. That's the upper end. It could be as low as 700,000, but a substantial number, hundreds of thousands of people could be over the age of 55.
Why are people with MS living longer?
They're living longer, I think, because of a couple things. Number one, we're probably identifying people with relatively modest disease who don't have any substantial impact in terms of disability and dying young with their MS. The second part, of course, is that we've developed effective therapies, and these effective therapies have reduced the likelihood that someone would develop progressive disability, diminish the severity of that progressive disability. And we also have just better ways to treat infections, better ICU care over time. It used to be in the old days that people would, for example, get blood clots in their leg and they would go up to their lungs, so-called, blood clots that would go up, and pulmonary embolism. And they would die from that on a routine basis. Now we can recognize that much better, and we don't have that issue. And this is not a trivial issue for our patients, because our patients, many of them are wheelchair bound, and that is potentially a risk factor for developing pulmonary emboli.
How does MS change as people age?
MS changes functionally in many different ways as people age. So pathologically, there are differences in the way the immune system is disrupted as people age. When people are younger, they have these highly inflammatory lesions with white blood cells leaving the periphery of their body, entering into their nervous system, causing these acute relapses. As they age, that becomes much less significant, and there's what's called compartmentalized inflammation, and there's so-called senescence of the immune system as well. And so all of those things result in clinical changes that we see with decreased relapses. And as I noted before, some significant component of people go on to have slow progression of disability. And that is much more prominent as people age. Radiographically, that's seen with people having less new active MRI scan lesions, but they still can have slowly expanding lesions, something recognized more recently. They can also have brain volume loss or shrinkage. When people are young, most of that shrinkage is due to MS. As people age, most of the shrinkage they have is actually due to aging. And so what we can think of as MS in older people, when they have slow progression, it is taking MS and plopping it onto the back of aging. And the two together are not good. And so doing whatever we can before people get old to limit that would be extremely important. So in addition, what we see that's relevant to the DISCO-MS study is that as people age, the benefit of these medicines seems to be more limited. That is, when people have these relapses when they're younger, the medications are very effective. When people have slow progression of disability, the medicines are much less effective. So that's a big change, and that's what was partly what prompted us going in to do the DISCO-MS study.
As you mentioned a moment ago, as we age, things change. We physically change. And as people with MS age, their MS changes too. How challenging is it for a neurologist to sort of determine whether that patient in front of them, are those changes due to their MS, or are they due to the fact that they're simply aging?
The question of what causes the problem as you age, is it MS or something else, is an incredibly important question, because number one, you would treat them very differently, and what you tell the patient will be very different. So the things that are very important over time are things related to vascular disease. So simple things, little white dots on brain scans can be due to MS, or they can be due to vascular disease, or orthopedic problems, spine problems, hip problems, knee problems. Those can absolutely affect your gait. So one of the main things that we have to do as physicians, as people age, is exactly what you alluded to, which is say, what the heck is causing this problem? And is this really something I have to pay attention to differently? You know, especially if somebody has some serious problem like increasing fatigue with shortness of breath. Well, that could be congestive heart failure and not MS. So we really have to become almost more like old-fashioned doctors that took care of a lot of different things, not just the MS. Whereas in young people, they mostly are pretty healthy, and we can focus almost exclusively on the MS. And so it's a mind shift for us when we see an older patient to think about all the other things.
I want to circle back to something you said regarding what you learned in the DISCO-MS study about some of the medicines not being as useful to the patient as they were when they were younger. Given that, what's a conversation that patient should be having with their neurologist after they're celebrating their 60th, 61st birthday?
So the main conversation that we should have with our patients over time, especially as they go over age 60, assuming they've been diagnosed with MS when they're 25 or 30, which is not uncommon, is, do I need to continue this therapy? And the decision is always going to be based on the same thing. What are the potential benefits of the medication? What are the potential risks of the medication? What are the potential costs of the medication? And if I go off, how does that change? What does it change with regard to my risk of having new disease activity or worsened disease activity? And how do I balance those risks and benefits out? And if for that individual person, the risks and benefits say, I should really stay on my medication, that's okay, but you should have that discussion so you have the best information available that would then say what's good for you. And everyone is going to be different in that regard. Everyone views risk differently. And so we can't say that there's one thing, one size fits all, and everybody should do the same thing. The reality is that there's, first of all, no one size in general, but it's definitely not going to fit everybody with regard to how they understand risk and what their comfort level is and what their family's comfort level is. I can tell you that one of the main reasons we had difficulty enrolling people into the DISCO-MS study was that many people are quite uncomfortable with the idea of going off their medication. But importantly, so are their spouses. And spouses and family members have an oversized influence on people when they make decisions because, like most people, we like to get help making complex decisions. And the spouses and family members play a very large role.
You know, we started our conversation talking about the fact that people are living longer. People with MS are living longer. Have you noticed that people are being diagnosed with MS at a later age than perhaps previously?
Yes, we and others have noted that the age at diagnosis seems to have gone up. So, for example, when I was in training, the standard dictum was that the median age or the average age that people would get diagnosed would be about 30. And there are multiple different studies, including our DISCO-MS study, where actually the average age at diagnosis was about 41. And that age has sort of moved up over time. And we've also begun to have the discussion about late onset MS. Late onset MS is by definition with first symptoms after age 50. That accounts for about 8% or so of people. And then there's very late onset MS over age 60. And that accounts for not quite 1% of people. So this concept that people are all 30 years old when they get diagnosed is not true. And that number has moved up over time for sure. And we see it, and we saw it in the DISCO data, and we've seen it in other recent studies as well.
Well, Dr. John Corboy, I want to thank you for all you do to improve the lives of everyone living with MS. And thanks so much for talking with me.
Thanks for having me, John. It's always a pleasure to see you.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/392. You'll find that link in today's show notes so you can easily copy and paste it right into an email or a text. Just a reminder that next week we'll have a whole playlist of video interviews from the ACTRIMS Forum featuring some of the leading experts in MS, and it's all going to be available on the Real Talk MS YouTube channel. Meanwhile, if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.